We are most grateful to Dr. Tamara Pringsheim for presenting this morning. She is Program Lead of Tourette and Pediatric Movement Disorders, Deputy Director of Clinical Research at the Matheson Center for Mental Health, Research and Education, President of the Tourette OCD Alberta Network, and is an evidence-based methodologist of the American Academy of Neurology. So over to you, Dr. Pringsheim.
Thank you. Thank you very much, Jillian, for that introduction. I'm very happy to be here and very happy that all of you have joined us this morning. I'm kicking off the next 6 webinars, which will be on various aspects of treatment for Tourette syndrome, focusing on the comprehensive behavioral intervention for tics, but then also addressing a lot of the other behavioral therapy and behavioral needs of children with Tourette syndrome. I'm just going to close. Julian, I assume I can close the poll here that's on screen.
Yes, yes, absolutely. I've closed it, so it shouldn't be there yet.
So my objectives of this lecture are to review the clinical phenomenology and diagnostic criteria for tic disorders, to discuss the natural history of tic disorders, to describe the epidemiology of tic disorders and common comorbid disorders, and to review recommendations on assessment and treatment of tic disorders. So let's start with the phenomenology and the diagnostic criteria. So a definition of tics. Tics are sudden, rapid, recurrent, non-rhythmic movements or vocalizations. You can also think of them as fragments of normal motor actions or vocalizations that are misplaced in context. We divide our motor tics into simple motor tics and complex motor tics. Simple motor tics are usually brief and meaningless movements. The ones we see most frequently tend to be eye blinking, movements of the eyes, such as looking to the side or opening the eyes wide, grimacing, wrinkling the nose, movements of the mouth, movements of the head and neck, shoulder shrugging, and abdominal tensing. It can literally be any type of simple, quick movement which affects the body. A complex motor tic is slower, it takes longer to perform, and it may seem more purposeful. We rarely see these in the absence of simple motor tics. So it could be touching an object in a certain way, having to even out, touch something on one side and then the other side. It could be a gesture used with the hand. It could be a pattern of movement. Sometimes we'll see people make twisting postures of their body. And then when people make obscene gestures, we call this copropraxia. Similarly, we divide vocal tics into simple and complex. Simple vocal tics are sudden, meaningless sounds or noises. The most common ones we see are throat clearing, coughing, sniffing. We also see little squeaks, barks, grunts, for example. A complex vocal tic is a syllable, a word, a phrase, or a statement. You can also see changes in the pattern of speech. So some people will have to really enunciate the first syllable of a word or certain letters. They also may change the volume of their voice. When people repeat the words that they hear of others, we call that echolalia. And when there are obscene, inappropriate, or aggressive words or statements, we call that coprolalia. I think coprolalia is probably the most famous feature of Tourette syndrome, but we only see this feature in approximately 10% of patients. So when we take a history of tics, we're looking for all these features to confirm our diagnostic impression. Tics are suppressible. So if you ask your patient, okay, I want you to try and hold in your tics, we're going to watch the clock and do this for 1 minute. Most people are able to do this. This may not occur in very young children, but children, as young as 8 to 10 are able to suppress their tics for short periods, though they do not. They say that it can be uncomfortable to do so. Tics are distractible in that if the patient is not thinking about their tics, the frequency of their tics is usually diminished. So when the mind is engaged and on a task, it is less often. The exception would be doing something like watching television, where you are a passive observer. Frequently, tics are more intense during such activities. Tics are suggestible, so that when you, for example, go through a tic inventory, often if you just mention the tic, do you have any sniffing? The patient will subsequently sniff. Do you have any coughing? They will cough. So bringing the tic to mind will often bring the tic out. Tics are variable, so the character of tics will change. The parent may say, well, for the month of June, we saw a lot of blinking. And then that went away. In the month of August, we saw a lot of shoulder shrugging. So these are constantly changing in location, especially for children. This is less true for adults, where tics tend to be more fixed in location over time. The frequency of tics waxes and wanes for reasons that we don't understand. So while there can certainly be exacerbations of tics during times of stress or excitement, sometimes tics go up and down in their frequency for no known reason. Tics are preceded by a premonitory urge, and up to 90% of patients over the age of 10 can tell you, I'm doing the movement in response to a need or an urge to do the movement. The closest example I can give to people who don't have tics, it's like the itch that precedes the scratch, right? So your brain tells you something's itchy here, and you go and you scratch. It's the same with tics. Patients will tell you, I get a sensation. It could be itching, it could be pressure, it could just be an internal feeling, I need to do it, and then I move my shoulder. It's that they have that premonitory urge. Again, younger children may not be able to articulate that, but most people over the age of 10 can say, I'm doing it, I'm driving the movement. So we think of tics as a semi-voluntary behavior, as the urge to tic is not voluntary. But the actual motor act or the vocalization is a voluntary capitulation to an irresistible urge. Okay, so let's talk about what the diagnostic criteria are for Tourette's disorder and the DSM-5. So you have to have both multiple motor and one or more vocal tics that have been present during some time, but not necessarily at the same time. The tics wax and wane in frequency, but persist for more than a year. The onset is before the age of 18, and it's not due to a substance or another medical condition. So what is the neurobiology of tic disorders? Now, this hasn't been fully worked out. We know that they're from neuroimaging studies, also from studies of neurophysiology, that there appears to be dysfunction within the dopaminergic pathways in the corticostriatocortical frontal circuitry. There have been other neurotransmitter systems that are implicated as well, including glutamatergic, GABAergic, noradrenergic, and histaminergic pathways. This is a highly heritable but genetically heterogeneous condition. So different family members can be have a different sort of dose effect, in that some can be mildly affected and others can be more severely affected. There also appears to be a strong genetic link between Tourette syndrome and OCD. So some family members may be affected by Tourette syndrome, other family members by obsessive compulsive disorder, and not have any tics. We also think that some environmental factors may play a contributory role, including a history of autoimmune dysfunction and a history of pre or perinatal adversity. So what is the natural history of Tourette syndrome? So tics usually start around the age of 6 and begin with tics affecting the face. The vocal tics typically appear after the onset of the motor tics. So tic severity reaches a peak between the ages of 10 and 12, and then tends to decline in late adolescence. So there is a high rate of natural improvement between the age of 14 and 17 years. And it is essential to monitor related impairment in order to guide clinical decision-making. So I just wanted to describe a nice study that was done in Denmark, where they have a national Tourette clinic, and they followed a large group of children for a period of 6 years. And they followed them to look at what happened to their tics over time. And they also looked at what happened to comorbid symptoms of obsessive compulsive disorder and attention deficit hyperactivity disorder. So in this study, it was found that the tic severity declined yearly by almost 1 point on the Yale Global Tic Severity Scale during adolescence. So the Yale Global Tic Severity Scale is the most common clinical measure for tic severity. And this is a clinically meaningful decrease over time. 18% of patients over the age of 16 had no tics, whereas 60% had minimal or mild tics, and that left 23% with moderate or severe tics. And they also observed significant yearly declines in the severity of OCD symptoms or ADHD symptoms. In terms of looking for predictors of the clinical course of Tourette syndrome, the strongest predictors of high tic scores and OCD or ADHD diagnoses in adulthood were their corresponding symptom severity in childhood. Being female and having childhood and the severity of childhood ADHD predicted future emotional disorders. So you can see that for many people, tic severity does improve with time. And so the prognosis can be very good in many patients. Now, the presence of comorbidity has a great impact on quality of life. And the comorbidity tends to be more disabling than the tics in many people. And we find that the psychosocial domains of quality of life are more affected than the physical domains. In children, the presence and severity of ADHD in those with tics has the greatest impact on quality of life. And in adults, the presence of anxiety and depression have the greatest impact on quality of life. So let's move on to talking about the epidemiology of tic disorders and the common comorbidities. So tics are more common in boys than girls, and it's by a factor of about 4 to 1. So about 1% of school-age boys have a chronic tic disorder compared to 1 in 400 girls. And this is a significant difference between the sexes. This is data from a Canadian study we performed a number of years ago using data from the Canadian Community Health Survey. This is a population-based survey of Canadians over the age of 12. And we found that the prevalence of diagnosed Tourette syndrome in people 12 to 17 was about 3 per 1,000. And again, you can see it's much higher in boys compared to girls, so 6 per 1,000 versus 0.5 per 1,000. And the prevalence of diagnosed Tourette syndrome in adults was lower. So you can see again in males it was 0.89 per 1,000 versus females 0.48 per 1,000. I think one of the interesting things here is that while you can see that the prevalence of Tourette syndrome in males decreased a lot in adulthood compared to childhood, it didn't change in females. So this suggests either differential symptom resolution, so that boys are more likely to resolve over time, or differences in health-seeking behavior between men and women. So looking at the characteristics of the Canadian population in that study, so compared to the general populations, Canadians with Tourette syndrome were less likely to attain any post-secondary education. They had a lower household income. They were less likely to be employed. And if they were employed, they were less likely to be employed full-time. Let's talk about comorbidity now. So I'm going to show you some data from a study which looked at the lifetime prevalence of comorbid psychiatric disorders and Tourette syndrome. And this was a large multi-center study of patients who had participated in some genetic studies of Tourette syndrome. So this data included people from North America, Great Britain, and the Netherlands. There was over 1,000 people in this study. And they found that 86% of people with Tourette syndrome met DSM-4 criteria for one or more comorbid disorders, while nearly 58% met criteria for two or more comorbid disorders. So OCD was present in 50% of their population, and ADHD in 54%. 30% had all three disorders, and 28% had Tourette syndrome only. Other common comorbidities in this population included mood disorders, which were present in 30%, anxiety disorders in 36%, disruptive behavior disorders in 30%. The other disorders, including eating disorders, psychotic disorders, and substance use, do not appear more common than in the general population. So in terms of who gets the different psychiatric comorbidity disorders, females were more likely to have depression, anxiety, and eating disorders. Males were more likely to have ADHD and disruptive behavior disorders. Adults and adolescents were more likely to have OCD, mood, anxiety, eating, and substance use disorders, and children were more likely to have ADHD. And I think all of this makes sense clinically. So let's move along to recommendations on the assessment and treatment of Tourette syndrome. I'm just going to check the time. So we're doing okay for time. If I start to run long, I will abbreviate the section on medication use, since I think there's a lot of small details, but my slides will be available on our website for you to peruse at your leisure. So I'm going to talk about the American Academy of Neurology Clinical Practice Guidelines, which we published in 2019. These are guidelines on the assessment and treatment of Tourette syndrome, and they are evidence-based. So they are based on a formal systematic review of the literature. So we made some counseling recommendations. As we discussed, the natural history of Tourette syndrome is very important. When we make treatment, like considering the natural history is very important when we make treatment recommendations. So informing families about the natural history of Tourette syndrome can help them make decisions. So it's important to let people know about the waxing and waning course over time, the fact that the worst time is between 10 and 12, and that many children will experience improvement in adolescence. Just telling that to a family can really help them manage their expectations. It often will take some of the anxiety around the diagnosis, bring that anxiety down. There's no evidence that treatment is more effective if it is started earlier. So we made the recommendations that clinicians must inform patients and caregivers about the natural history of tic disorders, and that clinicians must evaluate functional impairment related to tics from the perspective of the patient, and if applicable, their caregivers as well. And clinicians should inform patients and their caregivers that watchful waiting is an acceptable treatment approach in individuals who do not experience functional impairment from their tics. So if somebody is motivated to attempt treatment, clinicians may prescribe the comprehensive behavioral intervention for tics. I'm going to talk about this more in a bit. As a treatment option relative to watchful waiting. But the key here is the motivation. The patient has to be motivated to undergo the therapy because, as you know, doing habit reversal therapy is not a passive process. It requires active engagement of your patient. So if the patient is motivated, willing, and able, even though they're not experiencing disability from their tics, this is something that could be considered. And finally, if a medication is being prescribed for tics, knowing that there's that natural resolution that comes over time, it's very important to reevaluate the need for ongoing medical treatment. I typically will taper children off their medication after a period of 1 year and see whether or not it's still required. Often we'll choose the summer to do this. If tics are stable and there doesn't seem to be much waxing and waning, the tics aren't problematic, then I'll say, okay, let's gradually bring the dose down and see if you still need this. Let's see if it's different. And sometimes we don't need to restart, sometimes we do. But the point is you don't know unless you reevaluate. We also made some recommendations about psychoeducation with teachers and with peers in the classroom. So there is evidence that psychoeducation about Tourette syndrome with peers can result in a more positive attitude toward a person with Tourette syndrome, and that psychoeducation with teachers about Tourette syndrome can improve their knowledge about the condition. We feel that both of these things can positively affect people with Tourette syndrome. So we made a formal recommendation that clinicians should refer people with Tourette syndrome to resources for psychoeducation for teachers and peers, such as the Tourette Association of America. They are the largest patient support group in the world for people with Tourette syndrome. In Alberta, you can refer people to us, to the Tourette OCD Alberta Network. We do work with teachers and peers. We offer a service where we will provide educational in-services in the classroom that are directed to the age and educational level of children. We can also do presentations with teachers. So please do tell your patients about us. They can sign up for a webinar for their school using an online form. They can email Julian, they can call us, but this is our mandate and we're very happy to do this. So when we assess people clinically for Tourette syndrome, it's important to ask about their past medical history. So, have they been diagnosed with any comorbidities? Are they using medication? Often people with tic disorders have other neurodevelopmental disorders. So speech delay, for example, developmental coordination disorder, these are all more common in children with Tourette syndrome. I mentioned that this is a heritable condition with a strong family history, so I'll ask about family history as well. I see both children and adults, and many of my adult patients came to me through their children. I was evaluating the child and discovered that mom or dad was affected, and they became my patients as well. I ask about the history of tics. I perform a neurological exam to make sure that there is no secondary cause of tics. And I perform an assessment of tic severity, typically using the Yale Global Tic Severity Scale. Secondary causes of tics are uncommon. So that means that tics occur as a part of another disorder. It is true that neurodevelopmental disorders are common in people with tics. So ADHD is a neurodevelopmental disorder. Autism as well. We have higher rates of autism in children with Tourette syndrome than children without this disorder. Rarely we can see tics in other neurodegenerative conditions like Huntington's disease, for example. These patients will have other abnormal movements. Tics will not be the only manifestation of Huntington's disease, for example. This is a bit controversial, but there is some evidence that there may be an association between streptococcal infections and tic disorders. It is very controversial, but there appears to be an association. We can see tics in some people with as a part of Sydenham's chorea. Rarely, stroke or brain trauma can cause tics. And then tics can be induced by toxins. So typically it's CNS stimulant medication. So we can see an exacerbation of tics in some children who are given psychostimulants for ADHD. That being said, I would say that that only occurs in about 1 in 5 children who are given a psychostimulant. That means that 4 out of 5 children who are given psychostimulants will not have an exacerbation of tics. We can see tardive tics. This is an antipsychotic induced phenomenon. This is rare. I've seen this in patients who have been treated long-term with antipsychotics for psychotic disorders, for example. And there have been tics associated with a number of anti-epileptic drugs as well. So with the clinical assessment for tics, it's very important that we screen for comorbidity. So the main ones here, ADHD, OCD, generalized anxiety disorder, oppositional defiant disorder, and mood disorders. So when I see new patients at my clinic, I do screening for all of these comorbidities. We use ratings, we use screening rating scales for these disorders that children or parents fill out before their clinical visit. And then if people screen positive, we do a sort of a deeper dive into those symptoms so we can make an official diagnosis. So we made official recommendations about this in the American Academy of Neurology guidelines that clinicians should ensure an assessment for comorbid ADHD is performed in people with tics. And that clinicians should evaluate the burden of these ADHD symptoms in people with tics. And finally, that in people with tics and functional impairing ADHD, clinicians should ensure that appropriate ADHD treatment is provided. So I find that even though like I'm running a Tourette syndrome clinic, I probably actually treat medically more ADHD than tics. Because again, it's the ADHD that's causing most of the impairment for the child. So, you know, I'll do the evaluation and I'll say to mom and dad and child, what, you know, okay, we've got tics, we got ADHD. What's the main, what affects your life more? And I have to say 8 times out of 10, it's the ADHD symptoms. So I end up starting there with my treatment. We also made recommendations about the assessment and treatment of OCD, given how frequently it occurs in people with Tourette syndrome. So clinicians should ensure assessment for comorbid OCD is performed in people with tics and ensure that appropriate OCD treatment is provided. And as you know, the first line treatment of OCD in individuals with tics is cognitive behavioral therapy, specifically exposure and response prevention. So there is an increased risk of dying by suicide and attempting suicide in people with Tourette syndrome, which persists after controlling for psychiatric comorbidity. And the persistence of tics beyond adulthood, having a previous suicide attempt, and having a comorbid personality disorder increases the risk of death by suicide in people with tic disorders. So we did make recommendations that clinicians must ensure screening for the other comorbidities, including anxiety and disruptive behavior disorders, and that clinicians must inquire about suicidal thoughts and suicide attempts in people with Tourette syndrome and refer them to appropriate resources if these are present. I think it's very important to inform people, for people to have realistic treatment expectations. And while both medical and behavioral therapies can result in meaningful reduction in tics, these interventions rarely result in complete cessation of tics. You know, so some people will tell you, I want my tics to be gone. You know, if you put me on this pill, will my tics be gone? And I have to tell them that realistically, no. But you know that I hope for a 50% reduction in tic severity. And I would consider that as a meaningful improvement. If we don't reach that with the first drug we try, we can try something else. So when should we treat tics? There's really no set symptom severity threshold to determine when we should treat, and really treatment is an individual choice. So I recommend that the decision be based on disability. So I ask patients, are the tics causing pain? Are the tics interfering with your ability to perform certain tasks? Are the tics socially embarrassing? Like, are you not going out, or, are people bullying you, or do you feel humiliated in public because of these tics? Or are the tics emotionally distressing? And really the choice of which treatment to use should be a collaborative decision between the patient and the clinician. So let's talk a bit about behavioral treatment. So as I mentioned, you have 4 upcoming lectures on behavioral treatments following this webinar over the next 2.5 months. So I really hope that you'll join us for those, because they're going to be amazing, I promise you. So for those of you who haven't heard about CBIT, CBIT is the Comprehensive Behavioral Intervention for Tics. And this is a manualized treatment program, which consists of habit reversal training, relaxation training, and a functional intervention to address situations that sustain or worsen tics. And people with tics receiving CBIT are more likely than those receiving psychoeducation and supportive therapy to have reduced tic severity. And a randomized controlled trial comparing behavioral and pharmacological treatments for tics in children found that behavioral therapy is just as effective as pharmacological therapy. Parents are a lot more comfortable with behavioral therapy than pharmacologic therapy. So this is a very attractive treatment option. The main issue with this treatment option is availability. Right now, I don't know anyone outside of Calgary and Red Deer that are formally trained in behavioral in the comprehensive behavioral intervention for tics. So that's one of the reasons why we're offering you this training in the subsequent webinars in these series, so that more people will know about CBIT and be able to provide it to people in Alberta. So these are the recommendations we made in the guideline, that for people with tics who have access to CBIT, that clinicians should prescribe CBIT as the initial treatment option relative to other psychosocial and behavioral interventions. And for people with tics who have access to CBIT, clinicians should offer CBIT as the initial treatment option relative to medication. And that clinicians may prescribe CBIT delivered over teleconference or other secure delivery systems if a face-to-face option is not available. If CBIT is unavailable, other behavioral interventions for tics may be acceptable. And the one that has the most evidence after CBIT is exposure and response prevention. So I realize that I'm running low on time, so I want to give you the opportunity to ask me questions. So I'm going to go quickly through this. So antipsychotics are effective for tics. There are a number of antipsychotic medications that have been formally assessed in randomized controlled trials. That includes haloperidol, risperidone, aripiprazole, tiopride, pimozide, ziprasidone, and metoclopramide. There is no data on the relative efficacy of these drugs. In my own clinical practice, the antipsychotic medications that I think work the best and are the best tolerated are aripiprazole and risperidone. I almost never use haloperidol or pimozide. If I'm going to use a first generation antipsychotic, I typically use fluphenazine, even though we don't have the highest level of evidence on fluphenazine. This is a well-tolerated drug and very effective for tics. It is never my first choice. as you know, with antipsychotic drugs, there is a risk of a number of adverse effects. So they are not chosen first line for treatment. So they can cause movement disorders, and they can cause metabolic effects, and they can cause hormonal effects. And because of that, whenever one prescribes an antipsychotic medication, there is a lot of drug safety monitoring that must occur. So I do prescribe, but if I prescribe, aripiprazole or risperidone, that's 7 clinical visits a year with me. I see them monthly for the first 3 months, then every 3 months thereafter, because I'm monitoring for the drug-induced movement disorders, the metabolic effects, and the hormonal effects. So the medications can be prescribed safely, but it just requires a larger investment of time on the patient and the clinician. So we have to make sure that the symptoms are severe enough to justify the use of a medication that has that many side effects. So we made recommendations that antipsychotics can be prescribed when the benefits of treatment outweigh the risk, and that we need to perform that counseling on the various adverse effects that these medications can cause. It's important to use the lowest effective dose of an antipsychotic to minimize adverse effects, and that there should be proactive drug safety monitoring. There are some drugs that require monitoring of the QTC interval, and that would be pimozide and ziprasidone, or if the antipsychotic is being administered with other drugs that affect the QT interval. And that when attempting to discontinue an antipsychotic, the physician should gradually taper the medication over weeks to months, depending on how long the child or adult has been on the medication, to minimize the risk of withdrawal dyskinesia. We made recommendations on alpha agonist treatment for tics. And so the alpha agonists are clonidine and guanfacine. And in children with tics and ADHD, both of these drugs have demonstrated to have beneficial effects on both the tics and ADHD symptoms. There's no evidence regarding their relative efficacy. Certainly these drugs, they do have side effects. The side effects, the profile is milder compared to antipsychotics. So the things that we need to watch out for include hypotension, bradycardia, and sedation. And there can be QTC prolongation with the guanfacine extended release. And it's important to note that abrupt cessation can cause rebound hypertension. So we made recommendations about using alpha agonists, especially in children that have comorbid tics and ADHD, so that both conditions can benefit, and that these medications can be prescribed when the benefits outweigh the risks. That we need to do the counseling about the common side effects of these medications. Monitoring of blood pressure and heart rate should be performed, and that monitoring of the QT interval should be done if guanfacine is prescribed with other medications that prolong the QT interval. And that finally, these medications should be discontinued gradually. We made some recommendations about botulinum toxin injections for tics. There is a randomized controlled trial comparing botulinum toxin injection to saline injections, and this is a positive study. I find that this is probably the most popular treatment among my adult patients. The reason adults like it is because adults' tics tend to migrate less. They tend to stay fixed, and the most common areas affected are the face and the neck. So I can easily inject patients into the muscles that are producing the tics. And what they find is that it decreases the urge to tic, and eventually they stop doing the tic until the botulinum toxin wears off and I inject them again. So I inject a lot of people around the eyes, for example, and in their neck. So I'd say that this is a very tolerable therapy. I have very few children who want this treatment. I think I've had 2 teenagers who have opted to have botulinum toxin injections for their tics. There is some evidence for Topiramate, which is an anti-epileptic medication. This medication, it does have some side effects. I'd say that it has slightly more side effects than an alpha agonist, but slightly less side effect than an antipsychotic. It's not a first-line medication because the amount of data we have is less compared to the other drugs, but it can be a reasonable treatment alternative if that's Topiramate. And finally, there is some data on cannabis, though it is very limited. Right now, we only have 2 studies. One is an acute study, a single dose study, and the other is a parallel group 6-week study. Both are positive studies suggesting that THC has a favorable effect on tics. Patients will tell you, your adult patients will tell you that they do notice a diminution of their tics when they use cannabis. So we did make some recommendations regarding the use of cannabis, not in children, of course. So cannabis should be avoided in children and adolescents because of the association between cannabis exposure and harmful cognitive and affective outcomes in adulthood, not for pregnant or breastfeeding women. And also, I mean, in Alberta, cannabis is legal over the age of 18. But in some jurisdictions in the United States, for example, it is still illegal to possess cannabis. So we did make some recommendations, again, not as a first-line treatment, but that in people who are efficiently using cannabis-based medications, that clinicians offer to follow them from a medical perspective to make sure that that there is a good effect and that side effects are minimized. One of the important things about cannabis, specifically THC, is that patients cannot drive. So if they're taking a cannabis-based medication, we would advise them not to drive. So I'm sorry I had to go through that quickly, but I know that I want to give you the time to ask questions. I want to tell you a little bit about the Tourette Syndrome Clinic at the Alberta Children's Hospital, which is the only dedicated clinic for children affected by Tourette syndrome in Alberta. The Movement Disorders Clinic at the Foothills Hospital also sees adults with Tourette syndrome. So it's not a dedicated Tourette syndrome program, it's a movement disorders program, but almost my entire practice at the Foothills is adults with Tourette syndrome. So I would encourage you that if you see anybody in Alberta with Tourette syndrome who you think needs to see a specialist, that you refer them to us in Calgary. We see people from all over the province, and it just became easier now that we are allowed to use Zoom. So often I will video conference with patients from far, and then I will ask them to come and see me in person if I feel that I need to, do an in-person evaluation, but we can do a lot on Zoom. So it's really expanded our reach. There are 3 neurologists in total. So my 2 colleagues, Dr. Davida Martino and Dr. Justina Sarna, also have expertise in tic disorders and see both children and adults. We have a nurse, Tracy Hammer, who works in our clinic to assist us. And we have at the Alberta Children's Hospital Neuroscience Clinics, we do have limited psychology, PT, and OT support. I say limited because we are sharing these people with the entire division of neurology at the Children's Hospital. So they can't carry a very heavy clinical load from our patients. And just a plug about the Tourette OCD Alberta Network. We were funded by the Maternal Newborn Child and Youth Strategic Clinical Network from 2019 to 2022, and then we will transition to a nonprofit society. And our main goal is to provide care navigation for people affected by Tourette syndrome and OCD province-wide, and to provide education to mental health therapists across Alberta in the behavioral therapies for Tourette syndrome and OCD, so that people with these disorders can get the care that the behavioral therapies they need closer to home. As I mentioned, we provide education support and resources to people affected by these disorders, and we will work with educators to facilitate school success. And that is the link to our website, where you will find a lot of information. Please tell your patients about our website so that they can go there, and basically everything, all their informational needs are on our website, not just about Tourette syndrome and OCD, but also about all the different comorbid disorders. So there's information on ADHD, on depression, on anxiety. There's information on where they can see someone privately for CBIT or exposure and response prevention. There's information on the different crisis lines in the province. We have webinars for children and families as well. So please do tell them about it. So in summary, Tourette syndrome is a common childhood onset neurodevelopmental disorder. Many children will improve with time. All individuals with Tourette syndrome should be screened for comorbid psychiatric disorders. Behavior therapy is the recommended first-line treatment for tics. There are several medications that can help with tic severity. So with that, I apologize that it was so quick at the end, but I would be very happy to take some questions.
Thank you, Dr. Pringsheim. I can see we have quite a few questions already in the chat. You may want to just view those and see which ones to answer. While you're doing that, I will launch the post-evaluation for everyone to complete.
It was very exciting that we had people join us from from the United States, from the Philippines even. That's amazing. So thank you to those of you that have come to us from afar, and welcome to Alberta. Okay, so I'm just looking at the questions, wondering about clonidine to help with tics, as well as associated side effects of stimulants for kiddos with ADHD. Oh yeah, and so we talked about that. I just need to be patient. So yeah, so I do use clonidine when I'm trying to help kids that have both disorders, and I find that it is helpful for the core symptoms of both disorders. Does having OCD make tics worse? This is a very good question. So looking at my own research, I looked at tic severity based on, I compared tic severity in kids that had just Tourette, kids who had Tourette and OCD, and kids who had Tourette and ADHD, and kids who had all three. So children who have OCD, their tic severity is worse when we measure it using the Yale Global Tic Severity Scale. So this could be because this is a more severe phenotype of the disorder. That's possible. It could also be because the measurement is confounded. Sometimes it's very hard to tell the difference between a compulsion and a tic. So the measurement might be higher in those because of that measurement error. It is clinically, I would suspect that it's probably a little bit of both. So I think that people with OCD, their tics are a little bit worse, but then also our measurement is affected. Okay. How do they get referred? Access. So I think that you mean how do they get referred to the Tourette syndrome clinic? I'm going to take a leap that that's what you mean. So we'll take referrals from anybody. All you need to do, it's not like you have to meet criteria A through H to get into our clinic. We're not like that. If you have tics, we'll see you. All you have to have is tics and want to be seen, and we'll see you. So there's no predefined symptom severity or any other strict criteria. You don't have to see a psychiatrist first. You don't have to see a pediatrician first. If you have tics, we want to see you. We want to help you. And that is the case for both children and adults. Okay. Okay. So you spoke about secondary causes of tics being rare, but I was curious if you have any tips on how to differentiate tics from other phenomena. I work with teens and have run into a few where they say they have tics, but I'm wondering if it's more related to anxiety or emotional dysregulation. Any thoughts you have would be appreciated. So, tics are repetitive. They're preceded by an urge, and the most common tics that we see are of the face. So hard blinks, opening the eyes wide, darting the eyes in one direction or the other, wrinkling the nose, grimacing, opening the mouth wide, shrugging the shoulders, jerking movements of the arms, tensing the muscles, twisting the muscles. Those are all very typical tics. So if you go to the slide where I list the different tics, I would look through the list and see if that's what your patient's complaining of. If your patient's complaining of a very complex, strange movement and doesn't have any of those other simple movements, it may not be a tic. It may be something else like a compulsion. It could be like what we call a functional tic-like movement. But I think certainly if you have any question about, your patient has an abnormal movement and you're not sure what it is, we're happy to see them. In straightforward anxiety, we don't often see abnormal movements. We can sometimes people who are anxious can have motor restlessness where they're sort of always on the move. They're always like bobbing up and down, shaking their legs. But we don't typically see someone with tics in the setting of an anxiety disorder unless they have comorbid tics. And I have to say that in younger children, we have a very high rate of comorbid anxiety in children with tics, and they feed each other. The more anxious the child is, the more tics they have, the more tics they have, the more anxiety they have. So often treating the anxiety using behavioral therapy will often improve their tics. So move along. Is there any research identifying rates of tics in gender diverse populations? That's a very good question. So I'm not aware of any research on this topic, and I have looked. Anecdotally, I think I have more people in my practice who are gender diverse than I would expect. It's not uncommon for me to see someone who identifies as gender diverse in my clinic, but stay tuned. I think that this is an area of emerging research. I was curious if you had any information regarding the prevalence of students with Tourette syndrome who experience dysgraphia. Also, what are some potential accommodations that school-based interdisciplinary teams could implement to assist these students? So I don't have a hard number for you, but I can tell you it's so common. So many of the little boys in particular that I see have dysgraphia. So, learning disabilities are more common in people with tic disorders, and dysgraphia is very common. So, often I'll ask if the OT can get involved. Many schools will have an OT, and so I'll ask the OT to get involved to help the child. I ask about, I ask if the child can type and whether the school can provide access to a laptop or a scribe. Help provide notes, for example. And many of my students have successfully implemented these accommodations to improve their school success.